The X-ray showed a clean break, the leg is in a fresh cast, and the cast looks perfect. But the patient keeps pressing the call light, saying the pain is getting worse, not better, and the strong medication you gave an hour ago is not touching it. Look below the cast, at the foot. The toes are pale and cool, and when you touch them, he says they feel numb and tingly. The fracture is not the emergency in this room, the emergency is in the foot you can barely see. That is compartment syndrome. And the pressure building inside that leg can kill the muscle and nerve in a matter of hours. It is the perfect lesson for this whole system, because in musculoskeletal nursing, the injury you can see is rarely the emergency, the danger is almost always in the circulation, the nerves, the marrow, or the clots. By the end of this, you will read a neurovascular check, catch compartment syndrome and a fat embolism, protect a new hip, and understand the bone underneath it all. This is musculoskeletal nursing. All of it. Let's build it from the ground up. Chapter 1, Structure, and the One Rule. Here is the single skill that runs through every chapter of this course, the neurovascular check, done on the limb below any injury, any cast, any surgery. And it has a memory hook, the 6 Ps. Pain, especially pain out of proportion to the injury, or pain when you gently stretch the fingers or toes. Pallor, pale or dusky skin. Paresthesia, numbness and tingling. Pulselessness, a weak or absent pulse. Paralysis, an inability to move. And poikilothermia, a limb that is cool to the touch. The first 3, pain, pallor, and paresthesia, are your early warnings. Pulselessness and paralysis are late and ominous. Check the limb distal to the injury every time and compare it to the other side. The system itself is simple to frame. Bones give the body its structure and protect the organs, and their marrow makes blood cells, remember that, it matters later. Joints are where bones meet, cushioned by cartilage and held by ligaments. Muscles pull on bones through tendons to create movement. And when any of these is injured, the swelling and bleeding happen inside a body that has limited room to accommodate them, which is exactly why the pressure can rise and choke off the circulation and nerves. So the frame for the entire course is this: look past the obvious injury. The broken bone on the X-ray is what draws the eye, but the tested emergencies are the complications around it. Pressure building in a closed compartment, fat from the marrow traveling to the lungs. A clot forming in an immobile leg, nerves and vessels pinched by swelling or a tight cast. In this system more than any other, the thing that hurts the patient is usually not the thing you can see. Your job is to look for what you cannot. Our patient is Margaret, 74, who has lived alone and well until this evening, when she slipped on a rug and could not get up. Her right leg looks shorter than the left and is turned outward, and she is in a great deal of pain at the hip. She has broken her hip, the classic injury of an older adult with thinning bones. Her fracture will teach us the bone, the surgery, and the complications that come after. But first, fractures in general. Chapter 2, Fractures. A fracture is a break in a bone, and the 2 distinctions that matter most are simple. First, is it closed or open? A closed fracture stays under intact skin. An open fracture has broken through the skin, which means it is contaminated, so an open fracture is at high risk of infection and is treated more urgently, with antibiotics and cleaning. Second, the pattern tells you about the force. A transverse break is straight across. An oblique is angled. A spiral wraps around from a twisting force. A comminuted fracture is shattered into several pieces. And in children, a green stick fracture is an incomplete break, because young bone bends before it snaps. The names describe the line, but closed versus open is the distinction that changes how fast you move. Immediate care of a suspected fracture follows a few firm rules. Immobilize it, splint the limb, and the principle is to splint the joint above and the joint below the break so the fragments cannot move. Do not try to straighten it or push a protruding bone back in. Apply ice and elevate to control swelling in the early period. And then, crucially, do a neurovascular check below the injury, and repeat it, because the swelling that follows an injury is exactly what can compromise the circulation. The bone will be reduced, put back into alignment, and held there by a cast, or by traction, or by surgery. Which brings us to how we hold a bone still. Margaret's hip fracture is closed, the skin is intact, which is one worry less. But her legs shortened, outward turn position is the classic look of a hip fracture, the muscles pulling the broken pieces out of line. She will need surgery to fix it. Before that, we immobilize her, manage her pain, and check the circulation and sensation in that foot, because everything we just said about swelling applies to her. First, though, the casts and traction that hold a bone while it heals. Chapter 3. Casts and traction. A cast holds a reduced bone still, and cast care is heavily tested. While it dries, handle it with the palms, not the fingertips, which can leave dents that press on the skin. Keep it elevated and apply ice over the fracture site in the first day or two to control swelling. Pedal the rough edges with tape so they do not rub. Keep it dry, and teach the patient never to stick anything down inside the cast to scratch an itch, because a break in the skin they cannot see can become an infection. And the two things that must make you act: a hot spot or a foul smell, which suggests infection under the cast, and any of the 6 P's below the cast, which suggests the cast has become too tight and is choking the circulation. Traction uses a steady pull to realign a bone and reduce the painful muscle spasm around it, most often as a temporary measure before surgery. The nursing principles are a short list you can hold. The weights must hang freely, never resting on the floor or the bed, or the pull is lost. The ropes must be in their pulleys and not frayed. The line of pull must be maintained, so you keep the patient in good alignment and do not lift the weights. And with skeletal traction, where pins go through the bone, you watch the pin sites for signs of infection. Weights hang free, alignment maintained, pin sites clean. Margaret may be placed in a temporary traction to ease the spasm and pain in that hip while she waits for the operating room, or she may go straight to surgery. Either way, her leg is being held in alignment and her neurovascular checks continue. But casts and traction set up the single most important emergency in this course, the one from the cold open, because a closed space plus swelling equals rising pressure. That is Chapter 4. Chapter 4. Compartment Syndrome. Muscles are wrapped in tough sheets that divide the limb into compartments, and those sheets do not stretch. So when swelling or bleeding raises the pressure inside a compartment, after a fracture, a crush injury, or under a cast that is too tight, the pressure has nowhere to go. It squeezes the blood vessels and nerves shut, and the muscle inside begins to die from lack of oxygen, within hours. The hallmark, the one finding that should make you act before all the others, is pain that is out of proportion to the injury, and pain on passively stretching the fingers or toes. Then the rest of the 6 P's follow. This is a limb-threatening emergency, and the clock is short. So what you do, and what you must not do, are both tested. First, notify the provider immediately. This is an emergency. Remove or loosen anything constricting. If there is a cast, it is loosened or split, bivalved, and any tight dressing is released. And here is the counterintuitive part that catches people. You keep the limb at the level of the heart, you do not elevate it above the heart, because raising it further reduces the arterial blood flow into a limb that is already starving. And you do not apply cold, which constricts the vessels further. The definitive treatment is a surgical fasciotomy, cutting the sheath open to release the pressure. Notify, loosen, keep it at heart level, and prepare for surgery. Pause. A patient with a lower leg cast reports severe, deep pain that is not relieved by opioids, and it flares when you extend his toes. The toes are pale, cool, and tingling. What is happening, and what are your priority actions? This is compartment syndrome, a limb-threatening emergency. The pain out of proportion, worsened by passively stretching the toes, plus the pallor, coolness, and paresthesia, are the early 6 P's. Your priorities: notify the provider immediately, and loosen or split that cast to relieve the constriction. Keep the limb at heart level, not elevated above it, and do not apply ice, both of which would further reduce blood flow. Anticipate a fasciotomy. The pain unrelieved by opioids, with pain on passive stretch, is the classic early tell, and you do not wait for the pulse to disappear. Margaret's neurovascular checks stay normal: warm foot, good pulse, normal sensation. No compartment syndrome. Good. But her real risks are the ones that come from the fracture itself and from lying still, and they can travel to her lungs. Because the marrow inside a broken bone and the blood in an immobile leg are both about to become the story. That is Chapter 5. Chapter 5. When it travels to the lungs. Two complications of fractures share a frightening endpoint, something traveling through the blood to the lungs. The first is a fat embolism. Remember that bones contain fatty marrow. When a long bone, like the femur or the pelvis, is fractured, globules of that fat can escape into the bloodstream and lodge in the lungs. It is an early complication, classically in the first day or two after the injury, and the picture is a triad: sudden shortness of breath and low oxygen, a change in mental status, confusion or restlessness, and a distinctive petechial rash, tiny red spots, often across the chest and underarms. That rash, with breathlessness and confusion after a long bone fracture, is a fat embolism until proven otherwise, and the care is supportive, oxygen and respiratory support, fast. The second is the one immobility causes, a venous clot. A patient who is lying still after an injury or surgery forms clots in the deep leg veins, a deep vein thrombosis, which may show as a warm, swollen, tender calf in one leg. And the danger is that a piece breaks off and travels to the lungs, a pulmonary embolism, causing sudden shortness of breath, chest pain, and a racing heart, which can be fatal. So the entire game here is prevention. Early mobilization, get them moving as soon as it is safe. The compression devices that squeeze the calves. Blood thinning medication as ordered. And teaching leg exercises and hydration. You do not treat a clot you could have prevented. Pause. About 24 hours after surgery for a fractured femur, a previously stable young patient suddenly becomes short of breath and confused, and you notice a scattering of tiny red spots across his chest. What is happening, and what is your priority? This is a fat embolism. The timing, a day after a femur fracture, and the classic triad, sudden respiratory distress, a change in mental status, and the petechial rash on the chest, point straight to it, fat from the marrow lodging in the lungs. Your priority is the airway and breathing. Give oxygen, position him upright, support his respirations, and notify the provider and rapid response immediately, because he can deteriorate fast. The petechial rash is the fingerprint that separates a fat embolism from other causes of sudden breathlessness after a long bone fracture. This is why we do not let Margaret simply lie in bed. Her broken hip put marrow fat at risk in the first days, and her immobility puts clots at risk over the days that follow. So we use the compression devices, the blood thinner, and above all, we get her up and moving as soon as her surgeon allows. Which means we need to talk about that surgery, and the hip itself. That is Chapter 6. Chapter 6. The hip fracture. The hip fracture is the signature injury of the older adult, usually from a simple fall onto a bone weakened by osteoporosis, and its look is classic. The injured leg is shortened and turned outward, externally rotated, because the muscles pull the broken end out of position, and the patient cannot bear weight. It is repaired surgically, and soon, both to fix the bone and to get the patient moving before the complications of immobility set in. The repair is either a fixation with pins, screws, or a plate, called an open reduction and internal fixation, or, especially for certain fractures, a replacement of the joint with a prosthesis. And it is the joint replacement that carries a specific and heavily tested set of precautions. After a total hip replacement, the new joint can dislocate until the tissues heal, and the precautions all exist to prevent that. The 3 big don'ts. Do not bend the hip more than 90 degrees, so no low chairs and no leaning far forward, and you raise the toilet seat. Do not cross the legs or the ankles, and you keep a pillow, an abduction pillow, between the legs to hold them apart. And do not turn the toes and knee inward, no internal rotation. Keep the legs apart, the hip not too flexed, and the toes pointing up or out. Those 3 rules keep the new ball inside its socket. Pause, and select all that apply. A patient is recovering from a total hip replacement. Which of these actions are correct? Keep an abduction pillow between the legs. Bend the hip no more than 90 degrees. Cross the legs when repositioning. Use a raised toilet seat. And turn the toes and knee inward. The correct actions are the first, second, and fourth. Keep an abduction pillow between the legs to hold them apart. Bend the hip no more than 90 degrees. And use a raised toilet seat so the hip is not forced past 90. The other two are exactly what causes a dislocation. Crossing the legs is adduction, which you must avoid. And turning the toes and knee inward is internal rotation, also forbidden. Legs apart, hip not past 90, toes pointing up. Those precautions keep the new joint seated. Margaret does well in surgery, and her leg is repaired. Now the work is protecting the joint, preventing the clots, managing her pain, and getting her up and walking with therapy, early. But her fracture happened because a small fall met a fragile bone. And unless we address that bone, she will be back. So we treat the fracture, and then we treat the reason for it, which is Chapter 7. Chapter 7. Osteoporosis. Osteoporosis is the thinning and weakening of bone, where the body breaks down bone faster than it builds it, leaving it porous and fragile. And its danger is that it is silent. There are no symptoms until a bone breaks, often the hip, the wrist, or the spine, and a spine that slowly collapses can leave an older adult shorter and stooped. The big risk factors, being older, being a woman, especially after menopause when protective estrogen falls, a thin build, smoking, and low calcium and vitamin D over a lifetime. The point is that Margaret's fall did not have to become a fracture, it did because the bone underneath had quietly been giving way for years. So bone health is prevention and treatment together. Enough calcium and vitamin D through diet and supplements, because vitamin D is what lets the gut absorb the calcium. Weight-bearing exercise, like walking, which signals the bone to stay strong. And the common class of medication, the bisphosphonates, which slow the breakdown of bone. Those drugs carry a teaching point that is tested constantly, because they can severely irritate the esophagus. Take the pill first thing in the morning, on an empty stomach, with a full glass of plain water, and then remain sitting or standing upright for at least 30 minutes, and do not eat before the first food of the day. Upright, empty stomach, full glass of water. Pause. A patient is starting a weekly oral bisphosphonate, like alendronate, for osteoporosis. What is the essential teaching to prevent its most common serious side effect? Take it in the morning on an empty stomach, with a full glass of plain water, and remain upright, sitting or standing, for at least 30 minutes afterward, and do not eat during that time. The reason is that these drugs can cause severe irritation and even ulceration of the esophagus, so staying upright with plenty of water keeps the pill moving down and out of the esophagus. Lying back down, or taking it with little water, is exactly what causes the injury. Upright, empty, and a full glass of water. Margaret goes home with calcium and vitamin D, a weight-bearing walking plan with her therapist, a bisphosphonate and the teaching that goes with it, and, just as important, a fall prevention plan. That loose rug removed, better lighting, grab bars, a review of any medications that make her dizzy. We fixed the hip and we addressed the bone and the home that broke it. But not every bone and joint problem is a fracture, so Chapter 8 covers the chronic ones. Chapter 8, the chronic joint. Two kinds of arthritis are compared on every exam, and they are opposites. Osteoarthritis is wear and tear, the cartilage cushioning a joint wears away over years, so it hits the big weight-bearing joints, the knees and hips, and the joints you have used hard. Its pain is worse with activity and better with rest. It is often not symmetric, and its stiffness is brief. Rheumatoid arthritis is autoimmune, the body attacks the lining of its own joints, so it is symmetric, the same joints on both sides, it favors the small joints of the hands and wrists. And it comes with whole body signs like fatigue and low fever. Its stiffness is worst in the morning and lasts a long time. So, osteoarthritis, wear and tear, worse with use. Rheumatoid, autoimmune, symmetric, with long morning stiffness. One more painful joint to know, gout, where uric acid crystals deposit in a joint, classically the base of the big toe, which becomes suddenly red, hot, swollen, and exquisitely tender, so painful that even a bedsheet is too much. The care is medication for the acute attack and to lower uric acid, plenty of fluids, and avoiding the foods that raise it. The theme across all of these chronic joints is protecting function, balancing rest during a flare with gentle movement to preserve range of motion, managing pain, and joint protection. And when a joint, most often a knee or a hip, is destroyed by arthritis, it can be replaced. An elective version of what Margaret had after her fracture. The nursing after a planned joint replacement is the same music: control pain so the patient can participate, prevent the clots with movement and compression and blood thinners, watch for infection, and start physical therapy early to restore motion and strength. For a hip, the same dislocation precautions apply. The recurring lesson of this whole system is that recovery is movement, carefully, and early. Margaret's other knee has the aches of osteoarthritis, common at her age, managed with weight control, gentle activity, and pain relief. It is a reminder that an older patient rarely has just one musculoskeletal issue. But her story, a fall, a fracture, a repair, and the bone behind it, has now carried us through the heart of the system. A few more pieces round it out, in Chapter 9. Chapter 9, Rounding it out. Not every injury is a broken bone. A sprain is a stretched or torn ligament, the tissue connecting bone to bone. And a strain is a stretched or torn muscle or tendon. Both are treated in the early phase. With a memory hook you will use often: rice, rest the injured part. Ice it, to reduce swelling. Compression, with a wrap. And elevation, above the heart, to drain the swelling. Which, note, is the opposite of what you do in compartment syndrome, where you keep the limb at heart level. For a simple sprain, elevate. For the emergency of compartment syndrome, heart level. Knowing which is a classic distinction. When a limb cannot be saved, it is amputated, and two nursing points are tested. First, phantom limb pain, the very real sensation of pain in the limb that is no longer there, which you treat as real pain, not imagination, with medication and other therapies. And second, positioning to prevent contractures. After a lower leg amputation, you avoid keeping the stump propped up on a pillow for long periods, because a flexed joint that stiffens in that position can prevent the patient from ever using a prosthesis well. Believe the phantom pain, and protect the joint's ability to straighten. And a few that appear in children. Developmental dysplasia of the hip, a hip that did not form properly in the socket, caught in infancy and treated by holding the hip in the correct position with a harness. Scoliosis, a sideways curve of the spine, often found in adolescents, watched, braced, or in severe cases corrected surgically. And clubfoot, a foot turned inward at birth, corrected gradually with serial casting. The theme in pediatric bone problems is that early correction, while the child is still growing, gives the best result. Margaret's story was one older woman, one fall, one fragile bone. But through it ran the whole system: the neurovascular check, the fracture, the cast, the deadly complications, the hip precautions, and the bone health that should have prevented it. That is the point. So let's put it all together. Chapter 10, Put it together. Every musculoskeletal decision runs through the same 6 questions the next generation NCLEX is built on. What is happening? And here you always assess distal to the injury, the neurovascular check. Why? Which cue matters most? And in this system it is almost always a sign of the circulation or nerves being compromised, or of something reaching the lungs. What could I do? What do I do first? And did it work? Look past the obvious injury, check the limb below it, and you can walk into any of these. Back to the patient from the cold open. The clean fracture, the perfect-looking cast, and yet pain that is getting worse and not touched by strong medication, with a foot below the cast that is pale, cool, and numb. You had no framework then. Take a moment now. What is happening, and what do you do first? Walk it. What is happening? Compartment syndrome, pressure building inside the cast, is choking the circulation and nerves. Which cues? The early 6 Ps. Pain out of proportion and unrelieved by opioids. Pain on passive stretch, with pallor, paresthesia, and coolness in the foot. What do you do first? Notify the provider immediately, and loosen or split the cast to relieve the pressure. Keep the limb at heart level, not elevated, no ice, and prepare for a fasciotomy. The cast looked perfect. The emergency was in the foot below it. That is the whole system in one case. If you keep 5 things from this course, keep these. 1. The injury you see is rarely the emergency. Always check neurovascular status distal to it, the 6 Ps. 2. Compartment syndrome is pain out of proportion, unrelieved by opioids and worse on passive stretch, and you loosen the cast and keep the limb at heart level, never elevated, never iced. 3. After a long bone or hip fracture, watch for a fat embolism, breathlessness, confusion, and a petechial rash in the first days. 4. After a hip replacement, keep the legs apart, the hip flexed no more than 90 degrees, and no crossing the legs. 5. Teach bisphosphonates upright, on an empty stomach, with a full glass of water. One last one. A patient 2 days after a tibial fracture, in a cast, has increasing pain that now requires far more medication than expected, and reports numbness in the foot. A new nurse suggests elevating the leg high on pillows and applying an ice pack to help. How do you respond, and what is the priority? You stop those 2 actions and escalate. This is compartment syndrome, escalating pain out of proportion, needing far more medication, with numbness in the foot. Elevating the leg high above the heart and applying ice would both reduce blood flow to a limb that is already starving, making it worse. Instead, keep the leg at heart level, loosen or split the cast, notify the provider immediately, and prepare for a possible fasciotomy. The instinct to elevate and ice is correct for a sprain, and exactly wrong for compartment syndrome. Knowing the difference is the save. That is musculoskeletal nursing. Not just bones that break, but a system where the injury you can see is rarely the one that hurts the patient, and the save is looking past it, to the foot below the cast, the marrow in the blood, the clot in the still leg, the joint that could slip. There are over 1,000 free study guides at clinicaljudgern.com, no paywall, no catch. If this helped, like it, share it with someone in your cohort, and tell me which system to build next. Educational content only, not medical advice. Go be the nurse who checks the limb below the injury.